Hello, everyone. I hope you've had a great week. I'm here today to present my slides on clinical therapy for Ebola virus, and we're going to focus on Inmazeb, as well as the Zaire Ebola virus, which is one of the 5 subtypes of this virus. And here's a little summary of what our presentation is going to look like. We're going to go into what the virus is, transmission of it, clinical presentation, a little bit background information, and then we're going to go into the study itself, methods, results, discussion, the usual. So the Zaire Ebola virus, Ebola virus in itself is a single-stranded negative sense RNA virus enveloped in a lipid membrane and belonging to the filoviridae family. And as you can see, it's not like, it doesn't appear as the viruses that we are used to seeing, like the phages with their injecting legs, or the coronavirus with this like fearsome spikes. This looks like almost like a parasite. So that was interesting to me. And as we know, RNA is usually in its single-stranded form anyway. And the negative sense just means that the mRNA of this virus can be synthesized directly from the genome by the viral enzyme that it brings with it in its sequence, which is called RNA replicase. And the lipid membrane just makes it that much more formidable for against detection by the cell. And over here, we're going to the 5 subtypes of Zaire Ebola virus. And I thought it was cool that they were named after locations they were found in. And these 4 first ones are the ones that affect humans. This is the most virulent one in humans, and that just indicates that it has a really rapid, severe, and malignant course, as in, the fatality rates are up to 90%, averaging at 50. It's very rapid at that, and sudden too, symptoms appear very suddenly. And Reston is the subtype that also highly pathogenic, but this affects non-human primates. And the first 3 ones, Zaire, Sudan, and Bundibugyo, have caused really major outbreaks in Africa. And actually one of the studies that we're going to look at today, not one of the studies, this study that we're going to look at today, focused on a major outbreak in the Democratic Republic of Congo that started in 2018 because of Ebola virus. And it was a pretty major outbreak lasting a while. So let's move on. Here, I just want to show you how the virus gets transmitted, and pretty direct. The virus spreads through direct contact, from human to human or human to animal, through broken skin or mucous membranes in the eyes, nose, or mouth, or genitals, so unprotected sex, sexual transmission as well, or body fluids or blood. So even contact with infected medical instruments are bad, and contact with infected dead body, or infected fruit or bush meat. So these all can have risks of catching Ebola virus if these are also infected with Ebola virus. And I want to include this graph or illustration as well to show that infected fruit bats and non-human primates, as well as cows, can be carriers of Ebola virus, and they can be reasons and sources as to how it's passed on to us. So yeah. And let's move on to the clinical presentation. So Ebola virus incubation period upon catching it is 2 to 21 days. And that's, that can be the entire range, but the average is 8 to 10 days. And as aforementioned, it doesn't like appear right away. The symptoms appear after a while, but once it appears, it's very sudden. Like it starts with fever, fatigue, muscle pain, headache, sore throat. And prior to like this being called just like Ebola virus, it used to be called hemorrhagic fever. And hemorrhagic fever it's basically causes this horrible rash. And it's like your there's like blood clotting and internal bleeding spontaneously, and as blood like leaks from your capillaries and your blood vessels, it causes like this horrible rash. And this photo right here doesn't even do it justice. Like there were very much more graphic photos that I did not want to do that to you guys, so I didn't include it. But yeah, it appears all over your body, and I can only imagine how, bothersome and painful and horrible it must be. And, you can also, as the disease progresses, like the rash can turn into bruising, you can get diarrhea rash, I'm sorry, vomiting. You can get like damage to your kidney or liver, and as I said, like spontaneous bleeding, which I said internally, but can also happen externally. Like when I was looking at it, there were people with like their noses bleeding and their eyes bleeding, and it was pretty bad. And these are like some common lab findings if somebody with like a high viral load of Ebola goes to, doctor and gets these labs done, because they likely will with those symptoms. And the labs could likely show, one study found that these are very common lab findings among Ebola patients, which include acute kidney injury, abnormal serum potassium, and we all know how important potassium is for all of our cells. And elevated CRP. CRP is C-reactive protein, and this is like just shows that there's like increased acute inflammatory response, indicating that our immune system is active and fighting against something. Severe hepatitis, thrombocytopenia, and lymphocytosis. So these are immunological findings. And yes, let's move on. So now we're diving into the study. The study is pretty interesting. It was started in the Democratic Republic of Congo, like I said, in August 2018. And it started during like a major outbreak there. So I thought that was interesting. And they call this the PALM trial, as you can see here, Pamoja Tulinda Maisha. And this stands for Together Save Lives in Kiswahili language. It was a multi-center, open label, randomized, controlled 4-arm clinical trial. So the multi-center refers to like, they weren't only focusing on one region, like they worked in multiple medical centers. The randomized controlled is that, well, let me get into the 4-arm clinical trial first. The 4-arm clinical trial just explains that they tested 4 different they tested one control group, but like itself is a treatment, it's a therapy. against 3 other investigational agents. So the control group was ZMapp. It's like a triple monoclonal antibody. And the 3, what do you call it? Investigational agents were the antiviral agent remdesivir, and this is like a nucleoside inhibitor. It for RNA polymerase, it blocks its action basically. So that's what that does. And MAB 114 is a single monoclonal antibody, and what the researchers are really, looking at is the Inmazeb, which is also called REGN EB3, but we're just going to call it Inmazeb because that's easier. And so that's what the 4-arm clinical trial refers to. There's like 4 different treatments being given. And the randomized part, there was random assignment. I'm not sure if there was like random selection of the patients. I didn't really see anything of that being mentioned, but there was definitely a random assignment. What they did was they randomly assigned in 1:1:1 ratio, since there's 4 treatments, of these treatments to the patients, and the whole sample size was 673 patients, and the primary and efficacy endpoint was death at 28 days. So this just means that at like 28 days, that's when they kind of started looking at the results. And mortality at 28 days was one of the results that spoke volumes for them. And yeah. And another thing I want to mention was like they had a very open eligibility criteria, which like I'm gonna go into in the methods, but they basically accepted anybody who tested positive for Ebola virus, like any age and any gender, and it was like very open. So I thought that was interesting too, because usually there's very limited criterias. They had like just one restriction, which you'll see. And another thing I want to go into was like this map that I included. There was like a more detailed one that just looked at Butembo and Katwa, but this looks at like a greater area. And even though it's like almost 2 years after the study started, this is not related to the study, this is from somewhere else. It is nonetheless, like you can see, Ebola is still very prevalent. So that was interesting for me. And yeah, here's the legend for that. The red indicates confirmed cases, orange probable cases, but yeah, it's pretty bad. So let's go into the study methods. They basically, like I said, the eligibility criteria was interesting. Sorry. They basically accepted anybody who tested positive for the reverse transcriptase PCR assay. And that was like their first screening point of saying, okay, let's not go on to the next step. Basically, patients of any age were accepted, even neonates that are like less than 7 days old, as long as their mom was positive for Ebola. The only like restriction that I saw that like you can't be part of the study if you received like any other investigational agent to treat your Ebola within the last 30 days, except for vaccines. They allowed vaccines, and pregnant women were also allowed in the study. So it was like very, all come, all are invited. And all patients who were a part of the study received standard care for their Ebola. This includes like receiving administration of IV, aka intravenous fluids, daily clinical laboratory testing, and a lot of them as a complication of the Ebola had hypoglycemia and electrolyte imbalances, and these were also treated. And they were also given broad spectrum antibiotic agents and anti-malarial agents. So these aspects were all addressed. And in the random distribution of those four groups that I had aforementioned, 169 patients received ZMapp. They received it in the form of 50 milligrams per kilogram of body weight every third day beginning on day one. So they received 3 doses of that, and that's partial doses, multiple days, which please remember that because it's going to be a factor later on. And the remdesivir group, this was our RNA polymerase blocker. That was given to 175 patients, and that was given as a loading dose on day one as 200 milligrams. For pediatrics, that dose was adjusted. And that was followed by a daily dose of 100 milligram starting on day 2, continuing to 13 days. So that was a very long treatment daily of just receiving IV remdesivir. And yes, all of these medications, if I haven't mentioned yet, were given via IV. And MAB 114, that's our monoclonal antibody, MAB, that's what that stands for. And this was actually obtained from a Ebola patient, derived from Ebola patient. And this was given to 174 patients, and that was at a dose of 50 milligrams per kilogram as a single infusion, IV infusion, and just 1 dose, that's it. And then Inmazeb, that's what we're looking at, was given to a total of 155 patients, and they received 1 dose of 150 milligrams per kilogram. And that was also given as an infusion. And that Inmazeb is mix of 3 different antibodies, and those are also derived from humans. And they also did statistical analysis, which I didn't really want to delve into because it wasn't that interesting, and they just touched upon it very briefly without really providing figures or anything about it or analysis. So I didn't go into it, but they used Boschlu's test for hypothesis testing. They calculated type 1 error rate, and they adjusted their sample size, but it didn't make sense to me because when I look all over their study, their sample size is consistent, but over there they talking about adjusting. So that was a bit interesting. And yeah, those are the study methods. So pretty interesting stuff. And next let's look at the results. So they didn't have too much results, but what they did have was, promising enough for the FDA to approve it. This was one of the main studies that the FDA looked at. So their results show that in the Inmazeb group, which had the best survival rate, this was, we're looking at mortality rate. So mortality was only 33.5% in the Inmazeb group. So 52 out of 155 patients died. In the MAB 114 group, 61 out of 174 patients died, giving us a mortality rate of 35.1%. And the ZMAP group shows 84 out of 169 patients who passed, which gives a higher mortality rate of 49.7%. And the remdesivir group is 89 of 175 patients, which gives 51.3% of mortality rate. So another thing that was noticed, that when there was a longer duration of symptoms before treatment, this was associated with significantly worse outcomes. So those who just had the symptoms for a shorter period of time had better chance at, survival to begin with. And then this was like realized after looking at that 19% of the patients who arrived at the treatment center within 1 day of starting their symptoms died. Only 19%, compared to like the much higher percentage of 47% who died, who came to the treatment center like within 5 days. So you feel something, there's an outbreak, and you go to the center, only 19% died from that population. But you feel like you think you might have a cold, and you wait 5 days, and you're like, wow, this really might be Ebola. And then you go, out of that population, 47 passed. So that was something that they noticed. Another thing that they noticed, that the odds of death increased by 11% for each day after the onset of symptoms that the patient did not present to the treatment center. So like each day you're waiting, you're increasing your chance of death by 11%, which are horrible. That's such a rapid increase. And another thing they noticed was that the odds of death were lower among patients with lower viral loads, which makes sense. To me, it makes sense. Like, you should be able to attack the virus better if there's less of it, right? It makes sense to me. And the odds of death were higher among patients with higher viral loads, levels of creatinine, aspartate aminotransferase, and alanine aminotransferase. So if you had high levels of these laboratory findings, they found it, you also had high mortality rates associated with Ebola. So another thing that was noticed, which is clear from these two graphs, that Inmazeb, which is REGN-EB3, what we call it Inmazeb, is this green line over here, and you can see it's always the lowest, and that's like the incidence of death. And I'm sorry if I had not mentioned, all of these results are at 28 days. So remember, that was our efficacy. And so basically that green line is the Inmazeb, and as you can see, it's lower in all cases from all other treatments. And like remdesivir really doesn't seem that effective against Ebola. And the monoclonal antibody is also seems pretty effective. So these were promising results for the researchers. And they noticed the percentage of patients who died was lower among those who reported that they had received the vaccine as well. So if you received a vaccine against this, as I had mentioned before, there is a fact, it's not, that you can't get it, but it's like, getting an influenza shot almost. Well, I don't know if it's like the exact same thing, but you don't have total immunity against Ebola if you have the vaccine. But they noticed that these patients who do have the vaccine do have better survival rates. So again, vaccines, people, get your vaccines. Well, if it's relevant, you don't really need to get the Ebola rat. Well, yeah, get your vaccines that your doctor recommends. That's all. So patients who reported vaccination also were more likely to have had fewer days of illness. So that's another thing. Like if you had the vaccination, this was found to be associated with less days of illness, lower levels of alanine aminotransferase and all those other labs that I mentioned. So that was already giving you a higher survival rate. So yeah, those were our results, good results. And discussion. So this was, a good study. There was, prior to this, nothing to really promisingly battle Inmazeb. I mean, to battle Ebola. And FDA kind of jumped on this. They approved it in October 2020. I mean, this study was started in 2018, but it wasn't really published until 2019, the end of it, towards the end. And it was approved by October 2020. That's really good. I'm sure it was peer reviewed by then and other trials were done, but that's awesome. So it's currently being used as a clinical therapy for Ebola, against Ebola. And what's interesting is that it resulted in survival benefits both in patients with high viral loads and low viral loads. So like even if you come towards like the beginning of the illness or like towards the end of the infection, it still seemed to be effective. And it also demonstrated the importance of early diagnosis and treatment, because despite it being effective, even, somewhat effective, even on high viral loads, there's that 47% of those who died because they came in, 5 days later, not because they came in, but like, that's what was seen, that correlation was seen. So early diagnosis and treatment is important. So on top of like patients possibly waiting till later, like doctors need to be able to be effectively recognize this for what it is and include this in their differential diagnoses, because it can be lethal otherwise. It's very rapid death. It seems like 28 days. That's what the mortality they were looking at. And actually, I forgot to mention, there were those who died before the study could start even, and they had to be excluded. Like their starting number was higher, basically. I think like 22 people died before they can even start the study. And another thing that I thought was interesting, like I said, to like pay attention. Oh my God, I'm so sorry. That's my cat. Another thing I want to mention was that it's interesting that those medications that seem to not be that effective, the ZMapp and the remdesivir, as you can see, they have pretty high incidence of death overall and for high viral loads. These were given in like partial infusions over multiple days. And I'm just curious, like, I wonder if that has something to do with anything, like perhaps a different study could have been looked at. Like, I wonder why that's given as multiple infusions. So like, that's something that I could definitely look into. And yeah, Inmazeb is only given as a single full infusion. And it has that in common with the monoclonal antibody, which has, almost similar results. So I thought that was interesting. And yeah, thank you everybody for listening to this presentation, and here are my references. I hope you have a great weekend. Certainly hope that it's better than the week we've had. Okay, everybody, take care. Good night.